Getting tested for rheumatoid arthritis is not black and white, no matter what anyone says. Knowing what the test can tell us and what it can't is why I have a job, but I know how long it can take to get in to see a rheumatologist like me. This masterclass will cover all things rheumatoid arthritis testing and is a culmination of my top videos on the topic. You'll learn about the rheumatoid factor, the anti-CCP antibody, the ESR or sedimentation rate, and even about advanced RA testing, while of course learning how to take all this information and apply it to your situation. You'll see that filming and editing and even hairstyles have changed over the years, but what hasn't is my aim to provide you with the information you need to make the best health decisions for you. I'm Dr. Elizabeth Ortiz, and this is Connected Rheumatology. Let's get started. The rheumatoid factor is an antibody to an antibody. Now, you don't really need to understand all of that and the technicalities and the complications of that, but just know that the rheumatoid factor comes in a lot of different flavors. And if you're really looking for rheumatoid arthritis, you want to make sure the lab you're going to is checking for all of them. The rheumatoid factor can be seen in a lot of different conditions. So similar to that ANA, it is not particularly specific for rheumatoid arthritis. You can see a positive rheumatoid factor in infections, in cancers, and in other autoimmune conditions. It really comes down to how you're feeling and what your joints look like when you're trying to make a diagnosis of rheumatoid arthritis. You know, we have criteria that help us or guide us when trying to make a diagnosis of rheumatoid arthritis, and positive blood work is only one of those criteria. The chance of having a positive rheumatoid factor goes up as we get older. Now, our immune system, similar to us, gets old. And that means we have a higher, I shouldn't say old, it gets older with us. It gets wiser with us. As we get older, our immune system ages with us. And all that means is that the chance of having or producing a rheumatoid factor in our blood goes up. So the chance of having a positive rheumatoid factor blood test goes up. This doesn't mean that if you get this positive rheumatoid factor blood test, you are destined to get rheumatoid arthritis. It just means that you've got the blood test. Everyone and every positive blood test deserves to be evaluated, but a 15-year-old who has a positive rheumatoid factor blood test is going to get a bigger eyebrow raise from me than a 72-year-old who has the same test result. Just because that 72-year-old has a higher chance of having a positive blood test compared to the 15-year-old. If you do have rheumatoid arthritis, then your rheumatoid factor can be telling. Although it's not really common practice these days, back in the day, we used to follow rheumatoid factor to help us understand how our patient was doing. As in some individuals, the rheumatoid factor goes up and down with the person's disease. So for example, if someone was having a rheumatoid arthritis flare, their rheumatoid factor might go up as well. Now, these days we don't really do that. We have a lot of other more specific labs that help give us that information. And of course, we talk to the patient because the patient's really the best indicator of how they're doing. But just know that in some people, the rheumatoid factor goes up and down with their disease. Another point is that if you have rheumatoid arthritis and your rheumatoid factor is sky high. Now, of course, the definition of sky high is dependent on the reference range of the lab that you're using. But if it is particularly high, then we know that we need to be a little more careful and a little more diligent when watching your arthritis. We want to be a little more aggressive in making sure that we have controlled all of that inflammation. And the reason for that is we know that patients who have rheumatoid arthritis, who have very high rheumatoid factors, are at higher risk for having aggressive disease. So although the rheumatoid factor isn't particularly helpful at making a diagnosis of rheumatoid arthritis, it can actually be very helpful when trying to figure out the prognosis of a patient who has rheumatoid arthritis. These days, when you are trying to figure out if someone has RA, doing a rheumatoid factor is also done with a whole slew of other blood work. And the most important of those is the anti-CCP, otherwise known as the anti-cyclic citrullonated peptide. not easy to say. And the anti-CCP, we've been using this for over 20 years. It is much more specific and much more sensitive when detecting rheumatoid arthritis compared to the rheumatoid factor. And in fact, these days, we really don't do a rheumatoid factor without the anti-CCP. The anti-CCP test can be positive years before the person develops rheumatoid arthritis. So you can see how it's much more helpful. Now, as a rheumatologist, I've seen hundreds, if not thousands, of rheumatoid arthritis cases. So of course I've seen cases where someone has a positive CCP blood test and doesn't have RA, but that's very rare. And in general, if someone has a positive CCP test, I'm going to be much more concerned that they have RA compared to if they had just had the rheumatoid factor. About what even is the rheumatoid factor. The rheumatoid factor is an autoantibody. An antibody is simply a protein our immune system makes that is used to fight off foreign material. We make antibodies against bacteria, viruses, and even our food. Anything that our body identifies as not us. We also produce autoantibodies. These are antibodies that don't recognize foreign material to fight, but recognize our own tissues to fight against ourselves. Our immune system is constantly making autoantibodies, which is actually quite normal. And because of this, our immune system also has its own regulatory system, its own way of finding these autoantibodies and getting rid of them so we don't cause harm to our own tissues. When this regulatory system isn't working at 100%, autoantibodies and other elements of autoimmunity are allowed to perpetuate, and this can then lead to actual autoimmune disease. It's important to understand that autoantibodies generally have not been considered to cause the disease. We've described them as markers of possible disease, and in fact, I've described them as such on this channel. But even that is a bit of an oversimplification, because the reality is that it appears in some people the autoantibodies may be related to the development of disease, and in some people they're not. This is maddening, I know.
Are you kidding me? Are you kidding me?
But this framework allows us to understand the very real phenomenon we see, which is those with confirmed autoimmune disease are generally doing better when their autoantibodies are low or negative. Those without autoimmune disease can have positive autoantibodies and never develop anything. So with that out of the way, what are the signs that your rheumatoid factor may mean you have rheumatoid arthritis? Both of your hands and wrists hurt and get swollen, and this has been going on for at least 3 months. Now, not all hand pain is rheumatoid arthritis. In fact, most hand pain isn't. Our hands are a complex structure of multiple tendons, ligaments, and nerves, and we can get tendinitis, carpal tunnel, and osteoarthritis in our hand. All of these can also be associated with swelling, which makes things even more confusing. Having wrist and big knuckle pain and swelling specifically can be a sign. And in rheumatoid arthritis, these areas may even feel warm to touch. You have multiple joints aside from your hands that hurt and are swollen. Rheumatoid arthritis can affect almost any joint in the body except the low back. Low back pain is usually not RA. But elbows, shoulders, knees, ankles, feet, and even hips can be impacted. Again, what are we looking for? Is the joint warm to touch? Is it both joints, meaning both elbows, both knees, etc.? And here's a little hint. In rheumatoid arthritis, things tend to be symmetrical. You have positive blood work like a positive CCP antibody, elevated inflammatory markers, or other more subtle signs of inflammation like anemia or low vitamin D. The rheumatoid factor is never considered in isolation, and along with your symptoms, the rheumatologist is going to check a whole bunch of other labs. What we are looking for are general signs of inflammation and more specific antibodies for rheumatoid arthritis. So what am I talking about? What are these labs? So for inflammation, we look at 2 markers that tend to go up with inflammation. So the sedimentation rate or sed rate, also known as the ESR, and the C-reactive protein or CRP. We'll also take note if there are other more subtle signs of inflammation like anemia or low vitamin D. It's very important to remember that none of these blood test results are by themselves specific for rheumatoid arthritis, but are data points that we'll use. Most of the time, a rheumatoid factor is checked when we're feeling like crud, and it coming back positive can actually be an indication of something other than rheumatoid arthritis. We can see a positive rheumatoid factor with infections, other autoimmune conditions, and even more serious conditions like cancer. Now, this is not to scare you, just to help you understand that when you walk into any doctor's office with a positive rheumatoid factor, their thinking is actually quite broad. They aren't just going to ask you about your joints, or they shouldn't just be asking you about your joints. Viral infections are notorious for causing a positive rheumatoid factor, and if I see someone who was sick anytime near the blood draw, I'll want to repeat it once more time has passed. Also, other autoimmune conditions like lupus will often have a positive rheumatoid factor. Now, does that mean they also have rheumatoid arthritis? Not usually, although sometimes, but that's for another video. So what are some signs it could mean something else? Well, that's tough, because really the symptoms are so broad. Instead of listing the thousands of possible symptoms just to freak you out, it's more about what symptoms you don't have. If you have a positive rheumatoid factor and don't have a lot of joint pain, or perhaps the joint pain you have is mild compared to some of the other symptoms you have, then that's something your doctor is going to want to dig into. You can probably tell by now that figuring out if a positive rheumatoid factor means anything is art and science. Anytime you see a new doctor for arthritis or a possible autoimmune condition, your doctor will ask you pointed questions and probably run a slew of tests. But I want more for you. I want you to walk out of your appointment feeling confident in the conversation and plan you and your doc develop. And since I can't be everyone's doctor, and I can't make sure your doctor is well rested, well fed, relaxed, and in a good mood when you see them, what I can do is help you get organized and as prepared as possible to have the best appointment ever. Enter your appointment home run handbook, your absolutely free handbook that I've developed to help you tell your story in a way that will get you answers. I have a general version as well as a special rheumatoid arthritis edition, which has everything in the original version plus some extra information and thought exercises specific to rheumatoid arthritis. The link will be down in the description box below. And did I mention it was free? Okay. Back to rheumatoid factor. There's one more possibility, and that is it doesn't mean anything. Remember how I said that in some people autoantibodies don't lead to anything? Well, that definitely happens with the rheumatoid factor. The chance of having a false positive rheumatoid factor, which is just a scientific way of saying a positive rheumatoid factor that doesn't mean anything, that risk goes up as we get older. Why? Well, like everything else, our immune system ages and doesn't work at peak levels as we get older. That means that our regulatory system can falter and doesn't catch every autoantibody that's produced. So how do you know if this is you? If you are older than 65 years old, your doc will want to be extra careful when diagnosing rheumatoid arthritis. Now, why is this so tricky? Well, the chance of having osteoarthritis in our hands goes up as we get older, so it's very common to have some hand pain and stiffness and even notice our fingers bending or changing. You add on top of that a positive rheumatoid factor, and you would think a diagnosis of rheumatoid arthritis is a no-brainer, but it's not. The doc needs to pay extra attention to which knuckles of the fingers are the problem in all of your blood work. Your rheumatoid factor result is considered low positive. Like all other autoantibody results, the rheumatoid factor isn't simply a positive or negative, but is reported as a number. And although every rheumatologist has certainly seen low positive results in someone with very hot and swollen joints and vice versa, in general, if your result is only slightly positive, we consider that a good sign. Getting any positive autoantibody result back from the lab is never fun. We don't usually get them done when we're feeling great, and the anxiety and stress and figuring out what this result means can really drive us insane. The rheumatoid factor test is even more confusing because of that name. If you have been feeling sick, have joint pain, and find yourself facing a positive rheumatoid factor, then you absolutely deserve a thorough rheumatology consultation. Getting the right diagnosis the first time out is dependent on a number of factors, one of which is your level of preparedness and ability to partner with your doctor as y'all dive in and figure things out. Before talking about the antibody, we first need to talk about what is CCP. CCP stands for cyclic citrullinated peptide. I was in med school a long time ago, like in the early 2000s, and in the rheumatology world, CCP antibodies were all the rage, but I'm getting ahead of myself. To citrullinate is to, in biologic terms, take the amino acid arginine and turn it into citrulline. Remember, amino acids are simply the building blocks for proteins. Our DNA encodes for different amino acids that then come together to form all the proteins or peptides of our body. Citrulline is a necessary amino acid, but one that our DNA doesn't code for. So in order to get citrulline, to then build certain proteins, our body has a handful of ways to make it. One of those ways is to take arginine and citrullinate it and make citrulline. So what is a citrullinated peptide? Simply a peptide or protein that's got one of these citrulline amino acids in it. And so what is the anti-citrulliнаted peptide antibody? It's an antibody, more specifically an autoantibody, because it targets something in our own body that targets a citrulliнаted peptide. Okay, so now that we all understand the CCP test is testing for autoantibodies against a particular type of protein in our system, the citrulliнаted protein, we can now move on. So what, you might be thinking? Well, this autoantibody was found to be very specific for rheumatoid arthritis. You know how I'm always saying antibody tests can't diagnose you. We have to take test results in context of your symptoms. Well, this test kind of, tests that statement. It was found to be much more specific than the rheumatoid factor, which we had been using for decades to help us make a diagnosis for rheumatoid arthritis. Not only was it better at finding RA, it was better at finding RA much earlier. Finding and understanding the anti-CCP ushered in a new way of thinking about rheumatoid arthritis. We now thought about early disease and how to find it, and even completely redid our criteria that we used to diagnose RA. We did this in order to utilize this test and to find RA earlier. Coinciding with the research into this testing was the research into treatments. We could now find RA earlier and provide treatments earlier. This has changed what the life of an RA patient looks like. Gone are the days where we have to wait for bone changes or joint destruction. Gone are the days where we need synovial biopsies. We now have this blood test that was positive up to 10 years before someone got symptoms. So this was a big deal, to say the least. So what does the CCP test tell us? Well, like I've said, having a positive CCP immediately puts someone in a high risk category. Either they have a high risk of developing rheumatoid arthritis if they don't already, or they have a high risk of developing severe rheumatoid arthritis. So what do I mean by severe? I mean that they have a high risk of developing joint destruction that can lead to disability. They also have a higher risk of developing symptoms outside of the joint. Things like lung disease or vasculitis is more likely when you have a positive CCP. This brought along with a slew of research looking into how early we should provide treatment and how aggressive that treatment should be. Questions like, should we be slamming people with steroids even if they don't have many symptoms? Should we immediately start a biologic? Because all this came out right around the time that TNF-alpha inhibitors came out. You can guess the answers to those questions, given it is now 2024 and we do neither of those things. The reasons are nuanced and not really the point of this video, but suffice to say, the use of the anti-CCP antibody test along with biologics really changed the game. But it's never that simple, especially in rheumatology. Despite med students being taught to check an anti-CCP and diagnose RA, those using the test day in and day out were finding it wasn't as perfect as we had hoped it would be. We certainly still saw very sick and severe rheumatoid arthritis in those without this positive blood test. And as the years ticked on, we were seeing more and more patients with a positive CCP test who never developed anything. People we would have put in this high-risk category and even suggested slamming them with medications with enough time and experience showed us that they never really developed anything. Thank goodness we didn't expose them to those big-time meds. So what's the deal? This is where the little biology and testing lesson will come in handy. Remember, I said that the anti-CCP antibody is an antibody that we find in a lab test. Turns out, at least in some prelim data, that some of these anti-citrulliнаted peptide antibodies that we find in this test may actually protect us from RA. Now, there's still a lot of work to be done here. As a rheumatologist with more than my share of gray hairs, honestly, I'm not surprised. If there's one thing I've learned in rheumatology is that 1, lab tests are never what they are cracked up to be. And 2, the immune system is full of checks and balances. So the fact that some of the autoantibodies may cause disease and some may protect from disease, I don't know, seems about par for the course from my point of view. But how does this all pertain to you? My fave part is always taking all of this and giving you something to chew on. Some questions to think about and take with you to your doctor to keep this conversation going. 1, have you had your CCP checked? it will commonly be done even by primary care providers if there's concern for rheumatoid arthritis. What will make anyone concerned for RA? Well, the quick answer is joint pain and swelling in your wrists, hands, and feet that's lasted longer than 3 months. Despite what I just said about tests not being perfect, the anti-CCP test with the right symptoms is pretty telling. If you haven't had your CCP checked but have had persistent hand pain and swelling, should you have it checked? This will be a question for your doc, as they will need to assess what their concern for rheumatoid arthritis is. Remember, hand pain can be osteoarthritis too, so discussing this with them will be important. What if you had your CCP checked? How worried should you be? Remember, we never make decisions based on lab tests alone, even the CCP. Your symptoms are going to be much more important to your doctor than your blood test. That being said, if you are having significant hand pain, swelling, have high inflammation in your blood tests, and you have a positive CCP, then you may be diagnosed with rheumatoid arthritis. It's important to know that your doc will see that CCP as a risk factor for having severe disease and will want to be even that much more aggressive, or really I should say focused, on getting your inflammation under control. Great. So let's jump right in. First off, what exactly is the ESR? The ESR stands for erythrocyte sedimentation rate and is considered an inflammatory marker. Technically speaking, the ESR is simply a measure of how quickly your red blood cells settle at the bottom of a tube of blood over the course of an hour. The faster they settle, the higher the levels of inflammation in your body, thus the higher the sedimentation rate. But what's really going on here? Well, when your body is dealing with inflammation, whether it's from an infection, an autoimmune condition, cancer, or even trauma, your liver produces specific proteins known as acute phase reactants. It produces these acute phase reactants as a result of certain chemical signals it receives from damaged tissue to the body. You see, when we have inflammation in the body, regardless of what causes it, the inflammation leads to tissue damage. The damaged tissues then release chemicals that cue the liver to produce acute phase proteins. These acute phase proteins then change the electrical charge on the surface of the red blood cell, causing them to become stickier and clump together. It's pretty cool, right? Clumped red blood cells fall to the bottom of a test tube a lot faster than unclumped red blood cells, leading to a higher ESR. So how do we actually perform the test? Pretty simple. We draw your blood and place it in a special tube, leaving it to sit for an hour. During that time, the red blood cells gradually fall to the bottom, and the rate at which they do is then measured. And then you have your sedimentation rate. It's worth noting that this test doesn't measure any specific chemical or protein. It's purely a physical phenomenon that we're observing. So you can see how ESR is actually an indirect measure of the level of inflammation in the body. So what does your ESR actually tell us? Despite this test being commonly run in our clinics, hospitals, and urgent cares, how we interpret this result is often not explained or is wildly oversimplified. The short answer, it can either be helpful or it can tell us nothing at all. I know that sounds frustrating, but let me explain. First, let's talk about what's considered a normal ESR. If you've had this test done before, you might have noticed that anything above 20 or 30 millimeters per hour, depending on the lab, is flagged as abnormal. However, this doesn't necessarily mean it's abnormal for you. Your ESR can be influenced by several different factors, including your age and gender. So for example, women and older adults naturally tend to have higher ESRs, so a result flagged as abnormal might actually be normal for them. It's not uncommon for a woman in her 60s, 70s, or 80s to have an ESR result flagged by the lab as abnormal, but in fact, it's normal for her. We have a fairly simple math equation that we can use in this situation that can tell us if the ESR is actually elevated. But there are other scenarios where it's not as easy to calculate. Factors like your body mass index or BMI, metabolic syndrome, or even smoking can elevate your ESR. These are less straightforward to account for, and we don't have a simple equation to adjust for these influences, which can then make interpreting the result a bit tricky. Okay, so let's say you've had your blood tested and we've considered all these other factors and your ESR is still elevated. What now? What does it mean? The first thing your doctor will consider is how high your ESR actually is. This is a test where we don't simply consider positive or negative, but how high or how low. Numbers in the 50s or 60s or higher are definitely cause for further investigation. But equally important are your symptoms. I always stress how you can't separate the person from the blood work. Your symptoms are crucial in helping us interpret what your ESR actually means for you. For example, if you're experiencing joint pain, fatigue, or rashes, and you have an elevated ESR that's 2 or 3 times that of normal, this might point towards an autoimmune condition. On the other hand, if you're feeling well and your ESR is just slightly elevated, it might not be a cause for concern at all. Now, how do we use the ESR in rheumatology? If you've ever been suspected of having an autoimmune condition or have seen a rheumatologist, chances are you've had your ESR checked. But remember, the ESR alone doesn't diagnose anything. It's a general marker of inflammation, so it can be elevated in a variety of conditions like rheumatoid arthritis to lupus to vasculitis. In fact, the ESR is most useful when we can track it over time, looking for trends rather than focusing on a single result. That's why your primary care doctor might test your ESR, and then your rheumatologist might repeat the test a few months later to see if there's a pattern. In rheumatology, the ESR is used to monitor autoimmune inflammatory arthritis, such as rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. It helps us assess whether your arthritis is active and whether your treatment is working. But in other conditions like lupus, Sjogren's, or scleroderma, it can be less reliable. And in these situations, we really have to take everything going on with you into account. You guys know I love giving y'all some food for thought to think about in your own situation and take to your doctor's visits to keep these conversations going. If you have an autoimmune or inflammatory condition, find out if the ESR is one of the tests your doctor is regularly checking and start tracking it. As I mentioned, a one-time result doesn't always tell us a whole lot, but trends can tell us a lot more. If you haven't had your ESR checked in a while, ask your doctor, is my ESR something that should be checked and why or why not? This can be very helpful in understanding your doctor's point of view on your condition and how they are approaching it. If you are tracking your ESR already, one of the most important pieces of data is going to be, what was my ESR when I was first diagnosed? When we are first diagnosed with an autoimmune condition, we are often in a flare. During flares, we often have high levels of inflammation, and whether or not our ESR is elevated at this moment in time can tell us a lot about what we can expect from our lab results in the future. If your ESR was high when you were first diagnosed and you had a lot of inflammation, then you can expect your ESR to be a marker that goes up and down with your disease. If your ESR was normal when you were first diagnosed and you had a lot of symptoms of inflammation, then you might expect your ESR to not be as telling as you learn the flavor of your particular autoimmune disease. If you've had persistently elevated ESRs and haven't been getting any answers, it's worth asking your doctor if there could be other reasons it might be elevated. Do you fall into any of the categories we discussed that are known to cause high ESRs? We all, patients and doctors, love to hang our hat on it as proof that there either is or isn't inflammation going on. But as we discussed, like all my other labs, it has to be taken in context with the person, and tracking trends will tell you a lot more than just one result. In my experience, getting to a diagnosis of rheumatoid arthritis can take 2 distinctive paths. The first path, the easy path, starts with someone having joint pain that doesn't go away. They see their primary care doctor who orders some tests, namely the rheumatoid factor. Those tests come back positive, and then that person is sent to a rheumatologist. The rheumatologist agrees that the test results correlate with the symptoms, and then boom, a diagnosis of RA is made. The second path, however, is much less clear-cut. It can start the same. Someone has joint pain that doesn't go away. They see their primary care doctor who orders the same tests, but this time the tests come back negative. Because the tests are negative, a referral to a rheumatologist is never made, and another explanation for the joint pain is given. They may be told it's their weight,
their age, their lifestyle, or any number of things. But none of these explanations really seem to address it. This can go on for months or even years. There's crying, yelling, changing doctors, seeing non-traditional providers, trying anything to get relief. After enough crying, yelling, and failed supplements, they finally get in the office of a rheumatologist who diagnoses them with seronegative, meaning the blood tests are negative, rheumatoid arthritis. Could this months to years long frustrating journey be cut short with some more advanced testing? I'm going to argue that in some, yes, it absolutely can. In fact, we are already regularly using a more advanced test from Rheumatoid Factor, and that is the anti-CCP antibody. This antibody has been in regular use for RA diagnosis since the early aughts. In fact, I remember being a medical student hearing about the new amazing RA antibody. The anti-CCP changed the game in that it was much more specific for rheumatoid arthritis and was positive in those with RA years before they ever developed symptoms. Up to 30% of those previously classified as seronegative had a positive CCP antibody, showing us that we just weren't smart enough to find the antibody before. So the first and easiest step to take if you find yourself on that second torturous path is to get your anti-CCP antibody checked. This is a standard lab test these days and in fact is included in most RA testing panels. But what if you've already had these tests done and they are both negative? What would be the next step? The first one is the anti-MCV or anti-mutated citrullinated vimentin antibody. Say that 3 times fast. Similar to the anti-CCP, the MCV is very specific for rheumatoid arthritis. When researched, it caught just about as many RA cases as the anti-CCP did. But that has led to the question of, well, we already have the anti-CCP, why use something that's just like it? When biomarkers are first discovered and researched, they are initially researched in isolation. But in real life, we want to know how this would add to our current standard practice. And in the case of the anti-MCV, we aren't sure. We don't know how much better or not we would be at catching rheumatoid arthritis if we added the anti-MCV to our current testing with rheumatoid factor and CCP, which is why you won't see this test being done unless you or your doctor ask for it. And as we talk about the 2 other tests, this will be a recurring theme. The test may be good in some respects, but how does it add to what we already do? It's not clear. Okay, so the next test is the 14.3.3. This is actually not an autoantibody, but a protein in our cells that is elevated when we have inflammation. This protein and testing methods for detecting this protein have been around for a while, and although its trustworthiness is better than rheumatoid factor, it doesn't seem to be as good as the anti-CCP, and so it hasn't been largely adopted as standard testing. And then we finally have the anti-CarP antibody, which stands for carbamylated, which stands for something that I can't pronounce. Anti-CarP antibodies can be seen years prior to the development of rheumatoid arthritis, and their levels tend to go up right before someone is going to start to have symptoms. So why may getting these be useful? Well, I say this with a big caveat in that there is still a lot we don't know. But there is a case to be made that a subset of people who are negative for the rheumatoid factor and the anti-CCP may have one of these other antibodies, which would confirm a rheumatoid arthritis diagnosis and help everyone, the person with the pain and the doctor, feel more confident and comfortable about the path forward. It's likely a minority of folks that this applies to, but if you are going in circles trying to get answers, it may be worth discussing with your doctor. My doctor hasn't done any of these. Why can't I get these done? I've heard versions of these questions and complaints for years. Although I don't tend to be as cynical about it, it is true that there is a tension between public health and personal health and the approach that we take for each. When thinking about each, we must consider effectiveness, trustworthiness, and cost. So given all of this, I don't recommend jumping to these tests on day 1. But if you haven't gotten a firm diagnosis and you have been told you have seronegative RA and want more clarity, I do recommend asking your doctor about them. They may want to do their own research first, and keep in mind these tests may not be covered by your insurance policy. But as opposed to many of the autoimmune panels you can buy on the internet, these tests have real data proving their usefulness. It takes so long for something to go from studies to standard of care. That timeline frustrates all of us, but it also protects us. My mission here is to provide real-world, actionable, and grounded information you can use to navigate your own autoimmune care. If you support that mission, it really helps if you can like, share, and subscribe to this channel. And thanks for watching, and I'll see you next time.